The district that almost failed. There was a district hospital called Adom Health Center. At first glance, everything looked normal. Patients came in, nurses were busy, doctors were working. But something wasn't right. Maternal deaths were rising, malaria cases increasing, drugs kept running out, and the biggest problem, no one understood why. The crisis. One morning, the district health director called an emergency meeting. Why are things getting worse? He asked. Everyone had opinions. The pharmacist says, we don't have enough drugs. The nurse said, we are overwhelmed. The accountant said that there's not enough money. But then a young health planner stood up and said, we don't have a planning problem. We have an information problem. What is health planning like really? The planner continued. Health planning is not just making guesses. It is the systematic allocation of limited resources to achieve health goals. He wrote on the board, limited resources, competing needs, clear goals. Planning means deciding who gets what, when, and how. Then he paused. And let's be honest, once we decide some people benefit more than others, the room went quiet. Which means planning is political. And when they decide some people will benefit more than others, the political reality. The planner explained further. Health planning is a political process because it involves choices and compromises. You can't solve everything at once. It creates winners and losers. Some groups benefit more. There are competing interests, government, donors, communities. There is negotiation and bargaining. Decisions are not automatic. Power matters. Those with resources, influence, and data control decisions. He added something powerful. Even information is not neutral. Whoever controls data can shape agenda setting, policy decisions, resource allocation. Now everyone started to understand why things were messy. Let's start with information. The planner said, if we want to fix the hospital, we need accurate information first. He explained what good information looks like. Accurate, correct and error-free, relevant, directly linked to the problem, timely, up-to-date, not outdated reports, consistent, same story across different sources. Then he broke it down. We need different types of information: demographic data, population size, age, gender; epidemiological data, disease patterns like malaria rate; socioeconomic data, income, education, employment; service data, hospital attendance, drug usage. And don't forget, he said, quantitative data, numbers and statistics; qualitative data, people's experiences and opinions. How do we get this information? The team asked. So, how do we gather all these? He replied, we use proper methods of data collection. Surveys and questionnaires. Collect data from large populations. Key informant interviews. Speak to experts like doctors. Focus groups discussions. Understand community views. Direct observation. See what is actually happening on the ground. Then he warned them, be careful of bias, wrong data sources, poor measurement, selective reporting. To avoid this, we use triangulation, use multiple data sources, data validation checks, sensitivity analysis, test different assumptions. What happens if we ignore good data? The planner leaned forward. If we use bad information, we will get 1. Misallocation of resources. Drugs where they are not needed. 2. Wrong priorities. Solving minor issues instead of major ones. 3. Ineffective interventions. Plans that don't work. 4. Loss of trust. People stop believing in the system. The room nodded. They had seen this happen before. Understanding the problem, situational analysis. Now, he said, we move to situational analysis. This is where we deeply understand the problem before acting. He introduced key tools: SWOT analysis, PESTLE analysis, problem tree analysis, stakeholder analysis. SWOT analysis: strengths, skilled staff, existing facilities; weaknesses, shortages, inefficiencies; opportunities, partnerships, policies; threats, funding issues, political risks. PESTLE analysis: political, government priorities; economic, funding levels; social, beliefs and culture; technology, equipment availability, that's technological; legal, health regulations; environmental, sanitation and climate. Problem tree analysis: root causes, why the problem exists; core problem, the main issue; effects, consequences. Stakeholder analysis: who is involved, who has power, who supports or opposes. The planning cycle. Finally, the planner drew a circle on the board. This is the health planning cycle. 1. Situational analysis. Understand the problem. 2. Priority setting. Decide what matters most. 3. Plan formulation. Design solution. 4. Implementation. Take action. 5. Monitoring and evaluation. Check progress. 6. Feedback and revision. Improve the plan. The cycle never ends, he said. Planning is continuous. Principles that guide everything. Before ending, he said if we ignore these principles of planning, we will fail again. He listed them: equity, fair distribution of services; efficiency, maximum output from limited resources; effectiveness, achieving intended results; accessibility, services within reach; affordability, cost people can bear; transparency, openness in decision; accountability, responsibility for actions; participation, involving communities; inclusion, no group left out; flexibility, adapting to change; integration, coordination across sectors; decentralization, local level decision making; clarity, clear goals and roles. Months later, Adom Health Center changed. Drug shortages reduced, maternal deaths declined, staff worked better. Not because they worked harder, but because they planned better. So here is the truth. Health planning is not just about hospitals. It is about information, power, decisions, people. Get those right, and you don't just fix a system, you save lives. This is Sir Eric Podcast.